for diabetes. We also have with us on our agenda for this morning a presentation by Dr. Tamu Davidson on the CARPHA guidelines for diabetes, Module 3, um, which focuses on diabetes and caregivers. And we also have a presentation on mental health, diabetes and mental health, to be facilitated by Dr. Mike Campbell. And definitely there will be opportunities for questions both to the panelists this morning from you, the audience, our viewing audience, as well as the opportunity for question and answers with our um, guest presenters on the guidelines, as well as on the topic of diabetes and mental health. We invite you prior to the start of today's presentation to participate in a pre-meeting, pre-webinar Zoom poll, as well as invite you during the panel discussions to use the chat forum for the questions that you may want to pose to the panelists. And I have committed to moderating and facilitating these questions to the panelists for you. Thank you so very much once again for joining us on this fourth webinar that focuses on raising the bar, CARPHA's guidelines on the management of diabetes in primary care, and a focus on module 3, which focuses on caregivers for persons living with diabetes. The poll should be starting shortly. We're starting at this point in time, and we're asking you to participate by completing the poll. My apologies. And there are a total of 6 questions, so you're invited to scroll down to complete this process. you've not done the Zoom poll, we're asking you to go ahead and do so now. It is 7 questions in total. We're inviting you to share with us, and there will be a post presentation poll, so it will be important for you to participate in both of these. Thank you very much for your participation in our Zoom poll at this point in time. We invite you now to the discussions with our panel of experts in the area of who are caregiver experts in the area of diabetes. And our esteemed panel this morning comprises of Dr. Diane Brathwaite, who's the medical director of the Barbados Diabetes Foundation and the Maria Holder Diabetes Center for the Caribbean. Dr. Brathwaite is a UE trained physician who pursued postgraduate medical education in diabetes and endocrinology in the UK, and has, having graduated from the University of the West Indies, Dr. Brathwaite headed to the UK to answer questions that concern her most in terms of why it is that diabetes is causing so much unnecessary suffering in Barbadians and what we could do to prevent it. Dr. Brathwaite sees a wide array of clients and has a wide array of interest in the area of diabetes, but prevention and patient self-empowerment are areas she's heavily invested in. Dr. Brathwaite is a member of the Childhood Obesity Coalition and Childhood Obesity Prevention School Initiative. She's also an avid trained dancer and advocates and facilitates inclusive dance and arts programs. So she's not only a trained medical physician working in the area of diabetes, but also has an interest in the arts, more specifically in the as it relates to dance. On our panel also sits Dr. Mary Nancy Charles Larko, who is the directress executive for Fondazione Haite de diabetes et des malades cardiovasculaires. I hope my French has not butchered the attempts here. She is a physician and internist who is trained in metabolic disease, diabetes educator, published author and lecturer with a focus on diabetology and endocrinology. She is presently the ambassador for the Foundation de Haïti de Diabetes et des Malades Cardiovasculaires, lobbying and looking for grants and sponsors for the erection of a referral center, a center for excellence, as a one-stop center for individuals in Haiti. During the 2010 earthquake in Haiti, the foundation housed the only dedicated diabetes clinic in Haiti, which was not destroyed by the earthquake. And Dr. Larko has worked tirelessly to save thousands of diabetes patients in desperate need of medicine and intensive care. As a result of this, she has received many awards, including one from the International Diabetes Foundation, the IDF, in 2012, my apologies, for outstanding work in Haiti after the earthquake, and was also decorated in 2011 by the Rotary Club for the enormous work she has been doing for Haitian people affected with diabetes and cardiovascular diseases. Also sitting on our panel is a representative of the Diabetes Association of Antigua and Barbuda in the person of Miss Juanita James, who serves as the president of the Diabetes Association for Antigua and Barbuda. Ms. James is a retired chief nutrition officer and a member of the Wellness Committee of the Ministry of Health and the Environment in Antigua and Barbuda. She's a registered dietitian and nutritionist with over 30 years working experience, both in the hospital and community settings. She's a graduate of the University of the West Indies with a master's degree in public health, having worked both in the public health sector as well as in civil society organizations, namely with regards to the Diabetes Association of Antigua and Barbuda. And having a discussion on care and caregivers for persons living with diabetes would have been incomplete. Our panel of experts would have been incomplete if we had not had the addition of Adicia to it of the Antigua and Barbuda Diabetes Association. She's a 19-year-old and currently a second-year student at the Antigua State College. Her focus lies within the legal systems with aspirations of one day becoming a child advocate attorney. Ms. Stewart is the assistant PRO of the Antigua and Barbuda Diabetes Association, and most notably has been living with type 1 diabetes for the last 7 years. At this point in time, we now hand over to the esteemed panelists to whom I've just introduced you, who are within themselves experts in various areas of caregiving for individuals living with diabetes. And my first question this morning is to Ms. Stewart. How and when were you diagnosed with diabetes, and what has been your experience looking after your diabetes?
Good morning, everyone. I was first diagnosed with diabetes about 7 years ago. My aunt, she hadn't seen me in a while, and she realized that I had lost an excessive amount of weight, and she decided, hey, let me try and test your blood sugar to see if you are diabetic, because I do have a history of diabetes within my family. So that was the first thing that came to her head. So I was tested, and it turned out that my sugars were high. The machine couldn't read it, and I had to go on a fasting the next morning, and I tested my sugar again, and it was still in the 400s. So I ended up at the hospital where I was then diagnosed with diabetes. At first it was traumatic. It was hard. There was a lot of questions of why me, why did I have to be diagnosed with diabetes? How do I go on from here living with diabetes for the rest of my life? But my mother was also diabetic, so it wasn't that hard for me to understand how to take care of diabetes and what to do to prevent going into complications of diabetes. There were lots of challenges. There were a lot of challenges, especially with a lot of people who were uneducated about diabetes. It made it even hard on myself because, they would question me and I'll be like, am I doing the right thing? But then I would realize, hey, this is what is best for me and that's what I have to do. Diabetes to me, it wasn't a death sentence. So it made it easier on myself to say, hey, I can live a normal life just like every non-diabetic person, and that was the goal for me, to continue living a healthy life. And I've been doing that ever since I was diagnosed, have not been back in the hospital. And there are also challenges of high blood sugars and so, but it hasn't really affected me that much. But I am doing good, and I will continue doing good as I go on in my life. Thank you. Also, thank you for having me on the panel discussion this morning.
Thank you very much, Andisia. At this point in time, even before I funnel my second question to to another member of our panel, just want to remind persons who are our viewers this morning and persons who are attending this webinar that if you have any questions, that you may use the Q&A feature at the bottom of your screen to address questions to the panelists, and I will filter through those questions and facilitate asking on your behalf. My second question is to you, Ms. James. What has been your experience or the experience of the Antigua and Barbuda Diabetes Association as it relates more specifically to providing care for persons with diabetes?
Good morning, everyone, and thank you very much for having me on this panel as well. I've been with the Antigua and Barbuda Diabetes for many years, and as a not-for-profit civil society organization, we have over 30 years. We were established in 1986, primarily as a support group for persons living with diabetes and their families. And we operate under the motto of prevention, care, and support, and worked towards awareness, increasing awareness in the public, as well as education is a big focus for us, and advocacy. We highlight the importance of individuals knowing their risk for diabetes, and sorry, I had not started my video. Knowing their individual risk and promoting healthy lifestyle practices to reduce the risk, both of diabetes and the complications if they're already diagnosed. And we also promote early detection. Now, we do not operate from an office space, so that we don't offer services on a daily basis to our members or to the public. But instead, we focus a lot on education to increase both knowledge and skills for self-care, for self-management. That's an area of particular focus for us. So we conduct monthly meetings, and in those meetings, we address various topics on the management and the care of diabetes. So from nutrition to physical activity to self-monitoring, prevention of complications, medication, foot care, whatever it is. And we try to be as practical as possible to meet the needs of our members. We also offer in our sessions testing of blood sugar, and we monitor blood pressure. Although this may not happen at every meeting, but we aim to do that as far as possible to give people an opportunity also to learn how to respond to their numbers and how to solve problems so they can have improvement in that. We also provide some supplies when possible, and this is through partnership when we get donations. So testing supplies for persons who are not eligible to get them from the government pharmacies. And I must say that more recently, there has been a demand And we have had to respond to this demand for greater attention to be paid to psychosocial mental health issues. I don't know if, I think this started before COVID, but it has indeed been highlighted that this is an area that we have not paid enough attention to. So we are working towards paying more attention to those issues that also impact the quality of care and how people can cope with a chronic disease like diabetes. Communication is important. We really have to stay connected with our members, with the public, with our partners. And although that can be challenging and has been challenging, it's an area that we really continue to try to strengthen.
Thank you very much, Ms. James, for that response. And it is interesting noting here the demand that you have seen with regards to the requirements for the psychosocial mental health support in that area. And looking forward to the presentation later on this morning by Dr. Campbell as he seeks to address diabetes and mental health. But before I segue into that discussion, let me go ahead and turn my attention now to you, Dr. Brathwaite. What has been your experience as a medical doctor as it relates to providing care for persons with diabetes? Could you share that experience with us?
Yes, hi, good morning. Thank you for having me. At the Diabetes Center in Barbados, we offer what we call multidisciplinary care. So we have multiple care providers who are coming together to deliver care and education to persons living with diabetes, dependent on their needs. So therefore, obviously, there needs to be good kind of like communication skills within the team, et cetera, to do that. I'm going to kind of direct some of my comments towards post-COVID, because in reality, moving onwards, we're dealing with a post-COVID society. And I think there must be a lot of information that goes out. One of the challenges that I observed compared to the UK was that there was a lot of need for more self-empowerment and self-management education. And these must be delivered very early from the diagnosis. And we need to find ways to actually infiltrate this more into our healthcare system so that we're not faced with seeing persons who've had long-standing diabetes who don't have the kind of basic skills. With COVID, what we however saw, and this was interesting, there was a huge amount of anxiety. And what we observe is not just with patients, but also with the staff as well. And it's very important to evaluate the team that you're dealing with so you can maintain good kind of working dynamics with the people that you're trying to serve. I think that in the Caribbean, we have an opportune time, and COVID has highlighted this, to actually capture new diagnoses of diabetes and also people who are poorly controlled. We need to move from this paradigm of managing complications to early detection and regular and proper screening to change the face of what we see with diabetes in the Caribbean. COVID also showed us that we had lots of strangers knocking on our doors. And what that pinpointed to me is, and we know this already, there are a lot of people out there with diabetes who are either not controlled, they're not taking their medication, they're not seeking regular medical care. And we need to have strategic ways to actually target these people, etc. We've also embraced the fact that technology is with us, and we're going to have to embrace it and continue to kind of move on with it. And as we've seen the delays in care and healthcare seeking, we see the same thing with the diabetic foot as well. So just to empower people that they need to seek care very early, I think anytime that they have an issue. COVID has highlighted to us some important things. Weight gain happens. There's disruption in NCD care. There's a need to recapture people who have been lost to follow up. And we're seeing a second wave of depression and isolation among persons that is actually impacting on the ability to care. So I'll just listen to the rest of the panelists, and I guess we'll have a nice discussion as to where we kind of go from here. But I think it's an opportune time to actually shift what we're doing and make sure that we're doing the very basics and the very fundamentals very well. Thank you.
And so my question now goes to Dr. Larko. What has been the experience of the foundation as it relates to providing care for persons with diabetes in Haiti? sorry, Dr. Larko, your mic is still muted.
Is it now?
Yes, good. We can hear you now.
Sorry. Okay. So good morning, everyone, and thank you to CARPHA for inviting Vladimir to participate to that panel. So I should say that Haiti is in the middle of the English-speaking countries. So we had to develop something proper to Haiti so our patient could understand what was going on. Because there was, at the beginning of COVID, there was a lot of news and people, they were not really paying attention for the measures, the barrier measures. So we had first to start educating the population. So starting in beginning of March, we had a press conference for the journalists so we could give them hands-on to inform the population what was COVID, and also for patients with diabetes and their family, how they should prepare themselves to protect themselves. So we had a lot of communication going on, and that was not only for the patients and their family, but also for the general population and also for the caregivers. So usually we base our treatment advices on IDF standard of care and ADA standard of care. So we prepared documentation and we sent it to the caregivers so they knew how they should take care of patients with diabetes. And that was not something very different from all what it is saying, said outside, but it was mostly to address the problem, saying that it was there. Because if you follow the news, actually, Haiti, we are not really, we don't have a lot of death. We don't have the diagnosis, unfortunately, is not always done. And even the group which is in charge of making the diagnosis called Center of GSQ, they don't receive a lot of patients. So we know that the disease is there, but we have to work on that. So our patients who are used to come to Fadimac, who were used to come to Fadimac, at the beginning they were afraid to go out because they were saying if they go out as they have diabetes, they would have COVID. So we have to address that thought was not true. So invite them as our social workers to call them and ask them to come. Of course, we have all the measures put on as having the mask on, the social distancing. Usually our clinic receive about 40 to 50 patients per day. So we had to use another space to let them wait there and then one after the other come to see the nurses and the physicians. So it's still a challenge because the patient, they still don't understand, but also they don't really follow what they are supposed to do. So we also send our social workers and we use what we call the young leaders with diabetes, and we send them on the field to go and see the patients and see, of course, they are protected, but to see the patients and if there is any issue, call Fadimac, discuss with the team of care, and then if the patient is okay, so they can continue and follow for their next appointment. Otherwise, if they are very sick, they are advised to go to the hospital, and if they have to be to stay at the hospital. So we teach them what is the time they have to go, or if because it's better for them to stay home if there is no complication. So that's mostly what we have worked on different groups. So one with the press, secondly with the general public, and also to the patient and their family, and also to the caregivers so they know how to do. And also at Fatima, we prepare ourselves to receive any kind of patient so our caregivers are protected and also the other patients also. And I should say that in Fatimax, patients population, we noticed only one death from COVID. So that's something, and we tell them also it's not, you can have any other kind of disease, not only COVID. Actually, it's just COVID. So we ask them and we show them about the other symptom that they can have from their diabetes or the other cardiovascular disease, so they can take care of themselves.
Thank you very much, Dr. Larko, for this, and thank you to the rest of the panel for your response to the questions so far. And so now I have a question that is going to be posed to the general panel. So you're all invited to respond. What are the lessons learned, as well as the possible promising practices in providing care to persons with diabetes during the COVID-19 pandemic? Dr. Brathwaite had also intimated in her response that we would be required to look at a post-COVID-19 environment and looking at how it is that we continue to function in this new environment. And so the question now is, what are the lessons learned, as well as the possible promising practices in providing care for persons with diabetes, but as it relates to the COVID-19 pandemic? Dr. Brathwaite, since you had also intimated this in your earlier response, we could invite you to take the first stab at this question.
Yes, certainly. So I would say that diabetes and NCD care must go on, and it is a process that will require constant review and also updates towards its approaches. This care must incorporate technology, and it must engage the support of the family and the immediate community. It's also important to develop working partnerships with other people to capitalize on resources, especially as NGOs in this challenging financial time. I think it's important to really understand the real needs of the patient, and it even extends now at this time to the family as well, because that impacts strongly on what happens to the patient, especially if the patient relies on the family for support. There's a need to actively address misinformation and fears, and also mental strain. The mental well-being of your team is actually paramount and must be a high consideration as you are proceeding with your efforts. But as I said before, I think this is the opportune time to revisit prevention, early detection, screening in your country, and how you optimize this. And as I said before, we need to shift from being reactive to being preventive, and change the kind of burden that we are seeing with diabetes in our country.
Thank you for that response, Dr. Davidson. Any other persons with regards to our panel? Ms. Tuet or Dr. Larko, go ahead.
Yes, I would say that lessons learned, as my colleague just said, prevention. But to get to prevention, we have to, we must have a constant program to teach the patients and their family and the general public. If they are aware of the problem, they will participate, and of course, you will see the weight of their decision. So that's one of it. Secondly, because the social distancing, we had to develop other ways to contact our patients, and I think that we should continue with that, because in our country, like Haiti, the transportation is a problem, and it costs, and sometimes the patients are far away. So, and with a telephone or the video call, you can really know what's going on and give some advices that can save the patient's lives. And also, I would say the telemedicine, that's something also that we should continue with the caregivers, because when they are far away, it's very difficult for them to get new information. And by using that way of communication, and continue to use it, it will really improve their knowledge and also the care for their patients.
Thank you, Dr. Larko.
Yeah.
And yes.
I definitely agree with the other panelists. I think also, although we do have the means of communication, the technology is there, we have to be sure not to exclude persons who may not be able to access, certain, like the online meetings, etc. So the telephone is still quite useful. And also, in terms of being better prepared, to empower our persons living with diabetes and their family members to be able to take care of themselves. Because when they were not able to go to the health centers, visit their doctors, as they usually would, then of utmost importance is that they were able to problem solve and also to stay connected with persons who could support them and could assist them in whatever challenges they were facing. So I think that's really what we realized. Yes, there was a lot of fear, there was anxiety and all of that, but it was important to maintain communication with our members, with the public, wherever. And if we had ongoing connection, it was easier to do it if we were already in touch with people in various ways.
Thank you very much, Juanita. And this year, I would invite you then for your comments with regards to, as a young person living with diabetes, what is that shift that you see that would be required for us to make as it relates to providing care for persons with diabetes in a post-COVID-19 environment?
Agreeing with all the other panelists, I would want to say that education is really important, especially in this time. A lot of people are staying home, they're eating more, and obesity is a really big point right now. So it's very important that we send information out there to educate persons that, it's important to still take care of your health. Many people are not doing a lot of regular physical activities, so it's important that we educate people, especially people around persons living with diabetes, on the importance of taking care of a person living with diabetes, and also support is very important, especially from the public, persons around persons with diabetes. Support is really important. And yeah, that's about it. Support and education, most important thing at the moment.
Thank you, Andisia. Don't turn off your mic as yet. I'm going to go ahead and invite you as our last speaker. We go ahead and to invite all of our panelists to go ahead and provide within 30 seconds a key takeaway message that you'd want to leave with the audience this morning as it relates to our topic on the guidelines for providing care for individuals who are living with diabetes.
Can you repeat that for me, please? You were breaking up.
Just a 30-second key takeaway message that you would like to leave with the audience.
So my key takeaway message is to persons who have not been yet diagnosed or who may not be sure, get tested. Know your numbers. It's very important that you know your numbers. Know where you stand. If you are pre-diabetic, if you're not, continue exercising, keep a healthy lifestyle. For persons living with diabetes, I want to say, diabetes is not a death sentence. You can live just as regular as any person who does not have diabetes, and it's very important that you be optimistic, you stay positive in all situations. Diabetes does not control you. You must control diabetes before it controls you, and it's very important that people around you get educated, get invested in your life, in how you're living also, and that also can be beneficial for them also too. Very important to support persons with diabetes. It's really tough being a diabetic, and it's just really important that we have your support. Thank you.
Thank you, Andisia. So I'm inviting the rest of the panelists to go ahead, the rest of the panel to go ahead and to give us that takeaway in 30 seconds or less. Juanita?
Okay, I'll go. I think we need to just continue with the education and empowering our persons living with diabetes to be able to take care of themselves. We need to stay in touch, to keep connected with our members, with the public, with our partners. And I think it's a good opportunity for us to strengthen partnerships and not just with persons we have been accustomed to working with, but to embrace new partners as well.
Thank you, Juanita. Dr. Larko.
Juanita said almost what I wanted to say, so I will repeat. I would say that diabetes is a multifactorial condition. So everybody has to put their hand in and to make any kind of disease or problem, health problem, to have the patient with diabetes involved in. So one, the patient is in the center, but all the caregivers and other personnel who are working with them who can improve their condition should be there also. And as a region, it's very important that we continue those kind of discussion, not only discussion, but being action. And so we can move forward and make things successful for the patient with diabetes.
And by no means less, Dr. Brathwaite.
Yes, hi. I'm going to repeat some of what was said, but I guess that must be the main thing. The approach to care must be centered on education and self-empowerment, but there also must be a family-based approach and also a caregiver-based approach where they're actively engaged in the process for supportive persons. We must have more screening. We must empower people to see screening as something that is part of their regular care as opposed to a threat or a terror or something. And we also must learn how to treat the target. If we're not succeeding in treating the target very early, we must always ensure that we refer. Communication between care providers is so critical, and also accountability of the organizations that are providing care. And audit plays a very big part in that. Sometimes if you don't look at what you're doing, you don't know what your outcomes are really. And then finally, childhood obesity prevention is a huge issue. We cannot pretend it does not exist. There must be active efforts among the very young populations to look at this issue. And we cannot reduce prevalence rates of diabetes immediately. We know this, but what we can do is we can prevent complications if we manage diabetes well from the get-go.
Thank you again to all of you who've served on today's panel discussion. Thank you for a very enthused, very enriched discussion, and for providing us with the perspectives as it relates to the various roles that we all play in the youth, but that is required to be played as we look at a more patient-centered approach as it relates to providing care for persons who are living with diabetes. Thanks again to all of you who served on today's panel, and we would now move into the second part of our presentations this morning with the two presentations by Dr. Tamu Davidson, followed by Dr. Mike Campbell, and then to a question and answer section with the engagement of our captive audience. Allow me then to introduce to you Dr. Tamu Davidson, who is first the head of the Chronic Disease and Injury Department at the Caribbean Public Health Agency, a medical trained physician, as well as a public health graduate. Before joining CARPHA, Dr. Davidson worked as a medical doctor and a public health specialist for a combined 24 years in both urban and rural Jamaica at every level of the health system. She has held several positions, including physician research assistant, sickle cell unit UWI, district medical officer of health, regional HIV/AIDS STI program coordinator, medical epidemiologist, chronic diseases and injuries, and the director of disease prevention and control for entities. She is also a past lecturer in epidemiology and non-communicable diseases at the School of Public Health and Health Technology at the University of Technology in Jamaica. Welcome, Dr. Tamu Davidson, and we are inviting you, our captive audience, to remain engaged as she presents to us on the Diabetes Guidelines, Module 3, which targets caregivers for individuals who are living with diabetes.
Good morning, everyone in webinar land. And I'm pleased to present the final module for this year. And this is module 3 for the Caribbean guidelines for the management of diabetes in primary care. The focus of this guideline, module 3, is on guidance for persons with diabetes and caregivers. Sorry. So the outline of this presentation, we'll look at the background, some basic facts on diabetes, what to expect from your doctor's visit, managing our diabetes, foot care, immunizations that are recommended, and self-care for caregivers. So just as a point and a reminder for persons who may not be aware, the diabetes guidelines are really not new to the Caribbean. And there were previous versions of the diabetes guidelines, managing diabetes in primary care for the Caribbean in 1995, 1998, and 2006. There was also in 2004, the protocol for the nutritional management of obesity, diabetes, and hypertension in the Caribbean by the Caribbean Food and Nutrition Institute. So CARPHA developed these guidelines in collaboration with the OCS, funded by the WDF, and based on the WHO HEARTS and WHO's package of essential interventions. So the guideline takes a modular approach, and we are now looking at module 3, which looks at the guidance for persons with diabetes and caregivers. We covered module 1 and 2 and 4 over the past couple of weeks. This particular module 3 is targeting physicians, nurses, dietitians, nutritionists, pharmacists, and caregivers. So the model is also based on what we call the client-centered approach and focused and entrenched in a chronic care model. So a key element of good chronic illness care is to have informed and activated patients. And what that means is that patients are motivated, are knowledgeable, they have the skills, the confidence to effectively make decisions about their care and to engage in the management of their care. And that you have productive interactions with a prepared practice team, a team that's also motivated, that provides patient information and has the tools to provide a high quality care. All of this client-centered care approach is patient-centered. It revolves around the patient self-care, and the care is organized around their needs. It's team-based, multidisciplinary, different groups, professions, so the doctor, the nurse, the pharmacist, physiotherapist, the nutritionist, the dietitian, several members of the team that are all part of that care, including the family. And care is proactive and not reactive. So in looking at module 3, the structure of the content, this just highlights what is in this particular module, which covers risk factors for diabetes, signs and symptoms, to treatment and how to manage certain emergencies that are common to persons with diabetes, looks at goal setting, and looks at medicines, etc. So we will be giving an overview today and covering some components. This guideline in particular is really packaged and tailored for caregivers and persons with diabetes. So the aim of module 3 really is take into account the fact that really most of the time, a large proportion of time, persons with diabetes are not really in their doctor's office or in the health clinic. Most of their time they spend in the community. They spend time where they're living. And so it's important that they would have the knowledge and skills in order to manage their diabetes outside of those times. So some persons with diabetes may also be cared for by their family members, friends, home helpers, and that really have no prior medical training. And so this module aims to provide information and guidance that is easy to understand and follow, not very highfalutin, high medical terms, very technical terms, but it's easy to follow for both persons with diabetes and their caregivers, especially those who are not equipped with a medical background. And so in going through this, the module, I'll be covering material which will be framed in that context. So looking at some basic facts about diabetes, what is diabetes? And diabetes is described as a disease that occurs when your blood glucose, also called blood sugar, is too high. And there are three main types. So if we look at this diagram, and this is taken straight from the CARPHA guidelines, blood sugar control, when you eat your food, and that food is broken down in your stomach and intestines, and the glucose from that enters your bloodstream, and your blood glucose goes up. This causes the pancreas, which is an organ in the body, to secrete insulin. And insulin regulates that blood glucose by moving the glucose into the tissue cells for energy. So if that insulin, there's none, or the insulin not enough, or it doesn't work as it should, then the blood sugar will remain high as the glucose is circulating in the bloodstream. And so this is what happens in the case of diabetes. So there are three main types. Type 1, which can occur at any age, but typically occurs in young people. And this is where you have no insulin or just very extremely little insulin, and they need insulin to survive. And persons who have type 1 are on insulin. They have to be on insulin to manage their diabetes. Now, type 2 diabetes, in this case, insulin doesn't work as it should, and that's circulating. And this type 2 diabetes is the most common type. About 90% of diabetes occurs in this group. And very often, obesity and overweight is a driving factor. And then there's gestational diabetes, where there's high blood sugar during pregnancy and usually goes away once the pregnancy has ended. However, typically, these persons are at high risk for type 2 diabetes. And so that, in a nutshell, is diabetes. Now, if the sugar remains very high, that's circulating in or the glucose in the blood, then you can have many different types of complications related to diabetes. Many of persons will know about the diabetic foot, the diabetic ulcer. Sometimes that leads to amputation. You have nerve damage, heart attack, stroke, kidney disease, eye disease, and blindness are the common ones that we know of. But diabetes in and of itself affects their entire system. So what are some of the risk factors for diabetes? What puts us at risk? So they can be grouped into what we call the modifiable, and it should be non-modifiable risk factors here. Sorry, this was non-modifiable risk factors. And those are risk factors that cannot be changed. So being 40 years and older is a risk factor for diabetes. Having a first-degree relative belonging to certain ethnic groups, previously having diabetes in pregnancy, and previously having poor sugar control. And then you have so these are your non-modifiable risk factors, and then you have your modifiable risk factors. And those modifiable risk factors are physical inactivity, being overweight or obese, unhealthy diet, tobacco use, high blood pressure, and low levels of HDL, good cholesterol or high levels of triglyceride, and having depression is also what we call a modifiable risk factor for diabetes. So if we think of overweight and obesity, which is a major risk factor within the Caribbean region, the manual provides us with some guidance. Specifically, I want to highlight for populations in the Caribbean. Overweight and obesity is a driving factor for diabetes prevalence in the region, and is measured by the body mass index and the waist circumference. And here you can see the BMI and waist circumference, that measurements that are tailored to the diverse population within the Caribbean region. And this is also something that's very unique about this particular manual. Also, I'd also like to highlight, it's important that we address this risk factor, because overweight and obesity is linked to many other conditions other than diabetes. And by just reducing your weight by 5 to 10%, can really see improvements in your blood glucose, if you have high blood pressure, and other blood parameters, also improving how well your diabetes medication works. So these are some common signs and symptoms of diabetes. And this is not extensive, but diabetes, urinating often, being thirsty more than usual, being hungry, being more tired than usual, blurred vision is also another common sign and symptom of diabetes, tingling or numbness in the hands and feet, irritability, sudden weight loss without trying, cuts and bruises that take a long time to heal. And some other common signs are dark patches of skin on the back of the neck, the armpits or groin, frequent yeast infections, and sexual problems. But one thing to emphasize, like some other chronic illnesses, that you may have diabetes and not know and not have any symptoms. And so it's very important that you test. So if you're in a high-risk group for diabetes or you have any signs and symptoms, you should go to the doctor to get a checkup to be tested for diabetes. However, I'd even add, and this is according to CARPHA guidelines, I'd further add, we in the Caribbean, we're in a high-risk group. And as a part of your routine care, you should be checking for diabetes as a part of your annual checkup. So what should you expect from your doctor's visit? And so this is outlined in the manual. So for a caregiver who is speaking with someone who has diabetes or the person who has diabetes, these are some of the things that you'd expect. So you would go to the doctor would take what we call a history. So the doctor essentially asks you questions about any symptoms you may be having, such as tiredness, weight loss, any illnesses you may have, like heart disease or kidney disease or high blood pressure. If there's anyone in your family with diabetes, smoking and drinking habits, and you're feeling about the diagnosis and your ability to manage it. So these are just some of the questions that the doctor may ask. Also, the doctor will go on to do what we call a physical exam and medical tests. So your doctor will give you a checkup looking at your weight, height, blood pressure, tummy, eyes, skin, and feet. They'll look at blood tests for glucose control, kidney function, and cholesterol levels, and tests on heart function. So they may even order other additional tests depending on what they find. And then the doctor will then look at how will you be managed? What will they do for you? So once diagnosed, your doctor will put you in touch with other health professionals that can help you, a nutritionist to help you with your diet, other professionals with respect to your physical activity, a specialist to look at your eyes, heart, kidney, and a diabetes educator where they exist to help you to understand your disease and manage it. So if you need, your doctor will also put you on medications to help control your blood glucose, which may include tablets. So managing our diabetes is the next section that I'm going to be looking at. So in terms of managing our diabetes, the guideline provides you with 6 areas we'll look at: diet, physical activity, medication, blood sugar monitoring, high blood sugar, glucose, and looking at low blood glucose, and diabetes care schedule. So in terms of your diet, persons with diabetes need to take special care to ensure that their food intake helps them to maintain normal blood sugar levels throughout the day. And so this is critical. So these are some suggestions and tips that are in fact in the guideline with respect to that. So one of the things that we recommend is to ensure that if you have diabetes, you always have breakfast. And that helps you from overeating for your next meals. You ensure that you eat smaller proportions. And here we have some illustration of what a proportion is like, using a hand in terms of fats, proteins, and carbohydrates and vegetables. Also, you want to look at using foods from your 6 food groups in terms of what you will utilize for your diet. Ensure that you eat every 3 to 4 hours. So you'd have breakfast, a morning snack, lunch, afternoon snack, and a dinner. And also you want to drink more water, eat more lean meats, legumes, really avoid processed foods, eat more foods high in fiber, and a variety of fruits and vegetables. So really you take from a variety of the 6 food groups daily, but you want to focus more on more fruits, vegetables, and fibers. So what foods to avoid? Certainly sugary foods, sugary drinks, soft drinks, sweet drinks, foods cooked with oil, high in oil, butter, fried foods, fatty foods, and foods that are high in salt. In terms of avoid alcohol, if you're on a low-calorie diet as well. And if you're going to take alcohol occasionally, then it shouldn't be more than 1 unit.
Hi, good morning, everyone. It seems I was trying to determine whether the issue was on my end at first, but it seems that Dr. Davidson has dropped off, possibly with internet issues. Just allow me a minute to be able to try to reconnect with her. But in the meantime, I do invite you to use the opportunity to put your questions in the Q&A section, and we would inform you shortly in terms of the way.
Hello, sorry.
Yes, sorry, Dr. Davidson. Yeah, realize that you may have dropped off.
Oh, at what point did I drop off? Sorry. What point did in my presentation, did I lose my connection?
At this point where you were speaking to the issues on insulin here, on diet.
Okay, thank you. All right, so I was speaking to the nutrition facts, which is important to know. And one area that we have been advocating for is to have the front of packaging labeling, which would be easier, make it easier for the consumer and persons with diabetes and their caregivers to identify foods that should be avoided. So the next area is physical activity. And this is the brand new recommendation from WHO in terms of recommendation for physical activity in adults older than 18 years and older, and older adults with chronic conditions. In particular, what's new is that there's an increase in the number of recommended minutes for physical activity. And here, the recommendation is for at least 150 to 300 minutes of moderate intensity aerobic physical activity, where the older guidelines spoke to 150, and for 75 to 150 minutes for vigorous intensity activity. Where the older guidelines spoke to just 75. The recommendation for 300 and 150 were for additional health benefits. Another new area is the recommendation to have on at least 3 days varied multi-component physical activity that emphasizes both functional balance and strength training at moderate and greater intensity. And then for additional health benefits, this remains the same on at least 2 days of the week to have muscle strengthening activities at moderate or greater intensity that involve all major muscle groups. And for additional health benefits, it is recommended that you have 300 minutes or more for moderate intensity and aerobic physical activity, and 150 minutes for vigorous intensity activity. So these are the new guidelines that were launched in November on physical activity, which would not be reflected in your module and is an update from what is in the module. In terms of the recommendation, if you have diabetes and you're not able to meet the recommendation, then you should aim to engage in physical activity according to your ability. Adults with diabetes should also start by doing small amounts of physical activity and gradually increase in frequency, intensity, and duration over time. So you really want to start with small steps is the recommendation. And also adults with diabetes may wish to consult with a physical activity specialist or healthcare professional for advice, basically on the types and amounts of activity that's appropriate for their needs, abilities, functional limitations, complications, and medications and overall treatment plans. So essentially, looking at where they are in terms of their fitness level and what sort of treatment they're on, it's important to consult with these professionals. And then finally, is the recommendation that pre-exercise medical clearance is generally unnecessary for individuals without contraindication prior to beginning light or moderate intensity physical activity and not exceeding the demands of brisk walking or everyday living. And this recommendation more for those who are consistently or in some sort of care. But if you've never been into care and you don't know what your physical health is, it would be important to get a medical assessment done. So in terms of engaging in physical activity, it's important if you have diabetes to be safe when you're doing that. So one of the things you want to do is check your blood sugar before engaging in physical activity. And then, you know, you would gauge what you do based on your blood sugar level. You want to make sure you're wearing the proper shoes, drinking enough water. You want to make sure you warm up and cool down before and after physical activity. You eat a meal or a snack at least 1 to 3 hours before physical activity. And you eat and adjust insulin as necessary if you're on insulin. After physical activity, you want to check your blood sugar again. Also, you want to check your feet for any cuts and wounds. And also you want to ensure that you always have a snack in case your blood sugar drops. Persons who are insulin users should take their insulin at least 1 hour before exercise and inject in a non-exercise area. So the importance of checking your blood pressure before engaging in physical activity is critical. Where you, if it's 5.5 millimoles per liter, then you need to take a snack, about 15 to 30 grams of carbs, which is equivalent to half a cup of fruit or 2 raisins. And if the blood sugar is 13.3, then you need to check your urine for ketones. And you really shouldn't engage in physical activity as the blood sugar is high. So moving on to medication as a part of managing our diabetes or your diabetes. In the type 2 diabetes, medicines are typically used that are in a tablet form. But sometimes some clients may need insulin injections to get their blood sugar under control. So some may be on insulin. So the glucose lowering tablets, these oral medications, you need to ensure you're taking them as instructed and as prescribed. Some may have side effects, and if you have any side effects, typically they will go away, but it's important that you report any side effects to your doctor and the nurse and pharmacist. And in consultation with your doctor, then they can look to see how they can adjust your medication depending on what these side effects are. In terms of insulin injections, some persons with diabetes may be using insulin. And that may be another option that patients may be on. Patients would be trained as to how to administer these insulin injections. And the caregiver also can be trained to administer these injections as well. Storage of medicines is very, very important, that they're properly stored as instructed. So you want to ensure that they're in a cool area. They need to be in the refrigerator. They should be in the fridge at the required temperature. And most importantly, you should not take medicines that are prescribed by a doctor for someone else, as using medicines not intended for you can make you ill. And we know sometimes, very often, persons like to share their medicines. So blood sugar monitoring is another critical component, and your doctor may ask you to buy or you may be able to acquire a home blood sugar monitoring kit, or what we call glucose meter. So depending on which Caribbean country you're in, the glucose meter itself may be free. You may get that along with some glucose sticks as a part of the package of care. If not, you need to buy it. But it's very important that you check your blood glucose levels. It can tell you how well you're responding to the medication you're given, whether the medication is actually helping your blood glucose get under control. You can look at certain foods that you're eating to see how it affects your blood sugar level, so you can adjust your diet accordingly. And you can also detect if your blood sugar is going too low or is too high. And just by checking your blood sugar, it helps to give you some control in terms of your own health status, outside of going to the doctor or to a pharmacy or to the nurse to get them to check your blood sugar. And you really should keep a chart or a record of this blood sugar. So you can use a little exercise book, a notebook. Some of the machines come with their own form that you can utilize. So looking at blood sugar monitoring, two critical issues for persons with diabetes that need to be addressed. One is high blood sugar, which is called hyperglycaemia. And so what can cause the blood sugar to become high? It can be stress, eating too many sugary foods, not enough exercise, not taking the medicine as prescribed or the medicine not working, and taking other medicines like steroids. So how do I tell if it's high? Some of the symptoms you may experience are increased thirst, blurred vision, headache, frequent pain, rashes, frequent yeast infections, similar to when you probably were diagnosed with diabetes. So what do I do if I suspect that the blood sugar may be high? Well, the first thing you can do is quickly test it. If you're the person with diabetes, or the caregiver could also test it. Increase your water intake, change your diet, depending on how high it is. And if you're on insulin, you can talk to your doctor about adjusting it. However, very high blood sugar can be a critical emergency. And so if you're feeling sick, you're experiencing pain, diarrhea, rapid breathing, fever, signs of dehydration, drowsy, not being able to stay awake, then you really need to go in to see the doctor immediately. Or you can be taken to your doctor or the hospital. Because that means you may be going into what we call the diabetic ketoacidosis or hyperosmolar coma. So this can be a medical emergency that needs to be addressed. So on the opposite side of things, you have low blood sugar and or hypoglycemia. And some of the things that can cause it is having too little food, exercising more than normal, missing your meals or late meals, drinking alcohol, taking too much insulin, certain medicines that you're taking that are prescribed during your monthly period, hot weather, you have kidney, liver disease, thyroid disease, other conditions can cause the blood sugar to go low. So what are some of the symptoms you may have? Cold sweat, tingling, tremors, feeling of hunger, racing of the heart, feeling anxious, confused, slow to understand, blurred vision, feeling tired, aggressive behavior, coma, or change in a mood. And this is very important. If the client, the person with diabetes has fainted or is unresponsive, that you get them to the hospital as soon as possible. However, this algorithm here provides you with some interventions that you can utilize, and this is in the module. I'll highlight it, that you can do to address a low blood sugar if the person is unresponsive, and whether they're responsive, and what you can intervene and do in order to bring their blood sugar up if they're responsive, by giving them something sweet. So if the low blood sugar, you can give them about 15 to 10 grams of glucose or juice if available, something that can that has sugar or glucose that can bring their blood sugar up. And so if they're unresponsive, that's going to be a medical emergency. So this is on page 50 of the guideline, that a flow chart that we've made that's easy, that can be copied and kept by the caregiver or person with diabetes. So you have diabetes, and so what is your care schedule going to be like? So routine visits are usually every 3 months, unless their doctor may decide to have you visit them more frequently, depending on what's happening with you. So these are the regular office visits. You would test your HbA1c every 3 to 6 months, blood pressure checks, would be done, weight check, food check, and physical examination would be done as well. Your cholesterol and blood fat tests, kidney tests, and your eye exam as well should be done routinely. So in terms of other things that you should be considering is in the diabetic, and if you have diabetes, is foot care. This is a very common complication of diabetes, where you have the nerves in the feet can become damaged and the feeling feet can disappear, what we call neuropathy. Here, sometimes person with diabetes may get a cut, a wound, and may not even be aware, not even feel it. That can develop into an ulcer that doesn't heal and eventually amputate it. So these are 9 steps to take care of your feet if you have diabetes, in terms of washing your feet with lukewarm water, ensuring you dry your feet. It's important to just check your feet and look at your feet at all times, to check for any wounds or cuts, keep the feet moisturized, ensure that you wear clean socks that are not too big for you, ensure you're wearing the right fitting shoes, ensure to keep toenails at a reasonable length, and try never to walk barefoot, even in or outdoors. You know, I've seen that happen to persons going around for weeks. Patient turns up to you for a routine exam and doesn't even realize that they have a wound on their foot because they have not been checking. So that is critical in order to prevent amputations. There are immunizations that may be also recommended as well. These include the flu vaccine, the Pneumovax, the zoster vaccine for adults. These are additional vaccinations. And for children with diabetes, they should get their vaccines recommended for children for their age. This may vary from Caribbean country to country in terms of your vaccine policy. And I've put a question mark whether coronavirus vaccine will now become a routine recommendation. So just to highlight for caregivers, it really can be stressful or overwhelming dealing with diabetes, whether you're the caregiver or you're practicing your own care. So you really need to understand the illness that the client has, which is important in helping to deal with this caregiver possibly burnout. Ask for help, seek family support, take a break, keep in touch with friends is important, cultivate coping strategies that are important for you, check on your own physical health and check on your mental health and seek help from a trained mental professional. And also family counseling is critical. And one area that you need to really look at and address is you really need to consider and plan for managing how you will feel in the event that the client passes on and you no longer have to care for them. And so practicing these is a way of helping to manage and care for yourself. So the journey with diabetes is a partnership with your health team, family, friends, and community. It's important if you have diabetes to ask questions, seek help and support. And you've heard from the Diabetes Association. Today, persons living with diabetes as well from the earlier panel, share experiences with others who are on that same journey to help them along. And the journey can be a bumpy, winding road with wins and none, but you may slip off of that road in terms of managing your diabetes and your health, but keep trying and trying again. And of course, thank you.
Thank you very much, Dr. Davidson, for this presentation. I do know that we have some questions in the group, in the Q&A, reminding persons to continue to use that forum. However, we would answer all of the questions at the end of our second presentation. At this point, I invite you to help me welcome Dr. Mike Campbell, who would be presenting to us on diabetes in mental health. Dr. Campbell is a senior lecturer in behavioral science psychology with the Faculty of Medicine at the University of the West Indies, Cave Hill Campus, Barbados, where he serves as chair of the UWI Ministry of Health Research Ethics Committee and the Cave Hill HIV and AIDS program response program. He teaches in clinical psychiatry undergraduate and residency programs and publishes in the areas of psychological measurement, health psychology, and research ethics. His research has addressed key areas in Caribbean health psychology, including infection control, medication adherence, and sexual stigma, as well as provided empirical support for measures that are commonly used in regional and clinical research settings. He is the past president of the Barbados Society of Psychology, a member of the American Psychological Association, and an associate fellow of the British Psychology Society. He is editor of the Bulletin of the Caribbean Network of Research Ethics Committee. Thank you very much and welcome Dr. Michael Campbell to our last webinar on CARPHA's Raising the Bar, CARPHA guidelines on the management of diabetes in primary care, module 3, which focuses on caregivers and persons living with diabetes. I hand over to you.
Good morning, everybody. Hi, and thanks to CARPHA for having me. Since I'm working on 2 devices, I'm hoping that I have everything working correctly and that you all can see the PowerPoint.
Yes, we're able to. Yes.
Excellent. I have everything working, it looks like. So let me start with just a few key points that really I think others have raised a lot of these in the previous discussion today. So hopefully this will tie together some of the points that others have been making. So the first point is that mental health issues that might include a formal diagnosis from a doctor or psychologist are associated with diabetes, but there are lots of other issues regarding mental health and well-being that don't necessarily meet all the requirements for a diagnosis that can be part of the experience of diabetes, and it's important to be aware of those. Something that I think a lot of people would understand in this webinar is that the diagnosis itself can cause distress, and that mental health and stress are associated with outcomes in diabetes management. And because of that, mental health screening and integrated treatment that incorporates mental health issues improves outcomes for people living with diabetes. And finally, that some mental health medications can increase risk for diabetes. So it's important to look out for mental health in treating patients with diabetes. It's also important to look out for physical and metabolic health when treating patients with mental health issues. So I thought this quote really summed up the big picture very well. From economic, public health, and humanitarian perspectives, identifying and treating the mental health comorbidities among patients with diabetes should be a priority. I think it's accurate to say that most of the early research regarding mental health and diabetes focused on depression. And that's for good reason, because depression is 2 to 3 times more common in people with diabetes than in people without diabetes. And one of the important aspects of this to understand is that that relationship appears to go both ways, right? It's bidirectional, and there are a lot of factors in the system, but that's to say that diabetes increases risk for depression, but there's also evidence that depression increases risk for diabetes. And also, in fact, that depression or the experiencing of depressive symptoms with or without a formal diagnosis can complicate managing diabetes. A cultural approach is important. So like a lot of things, you know, there has been tons of research in the US, in North America generally, and some in Europe. There has been research in the Caribbean, but we need more. And a cultural approach is really important when you're talking about perceptions and behavior change. There might be quite a bit of overlap, but one size doesn't fit all. And in fact, just the question of how common depression is varies across cultures and regions. So it looks like that, you know, rates of depression may vary in different parts of the world, but also at the same time, a lot of the instruments that clinicians and that researchers use to measure depression are not validated. That is to say, there's not a lot of information to establish how they work in areas outside of where they were developed originally. So there's an important need in the Caribbean and elsewhere to make sure that these measures that we use to get a handle on depression and distress are actually measuring what we think they're measuring and doing it well for people in the Caribbean. And the final point here, that depression is associated with poor outcomes, is really important. So that if depression is in the picture, it's really doubly important to address it so that diabetes outcomes are not additionally negatively affected. So I included a couple of slides here, a few slides on a study we did a few years ago in Barbados, where, like a lot of the Caribbean, the prevalence of type 2 diabetes is quite high. This study from Anselm Hennis and colleagues found that almost 18% of people in Barbados are diagnosed or meet criteria for diagnosis for type 2 diabetes. And so an important question is, what's the associated burden of disease in terms of depression and quality of life more broadly? So we did a survey of 132 people that were patients in outpatient diabetes specialist clinics, both in public and private settings. You can see there, mean age was 53. Most of the participants were women. Nearly all of them were Black Caribbean, 41% married. One interesting thing is that in this population of patients with diabetes, unemployment rates were higher than the overall employment rate for Barbados at the time. And also educational levels were lower than for the general population. And we asked them to respond to questions on 3 measures. One measuring symptoms of depression, another instrument measuring quality of life, actually 2 other instruments measuring quality of life. And I'm just going to talk about depression. I should add that this particular instrument, the Beck Depression Inventory, does actually have some data supporting its use in the Caribbean. So there is data from Barbados and data from Jamaica suggesting that the Beck Depression Inventory actually is a pretty good measure of depression. So that's why we chose it for the project. And so this is not a true estimate of the prevalence of depression because we did not have a large enough sample, and we didn't select the sample randomly. But it does give us some indication of how patients were reporting depressive symptoms. And what you can see here is that most reported minimal symptoms, but in fact, 35, so a little more than 1 in 3 had some level of depression that, at least in terms of their score on the measure, suggested that some follow-up would be important, that this was at least a matter of concern to look at further. And as in other studies internationally, what we found is that depression, the depressive symptoms that people reported, correlated, right, were related to some important outcomes for diabetes management. Diastolic blood pressure, that's the lower number. So people who were more depressed tended to have higher blood pressure. They tended to have higher cholesterol levels and higher LDLs too. Interestingly, in our study, depression wasn't correlated with HbA1c. It has been in other studies, but not in ours. It may be that our sample was too small, or it may be that that there is something different going on in the population of Barbados. So this slide points out that there are a number of biological mechanisms that diabetes and depression actually share. And this is something that, you know, might not be intuitive to everybody. It may be more intuitive to the healthcare professionals, to the clinicians in the audience. But some of the environmental factors like neighborhood poverty, adverse child experiences contribute to both depression and risk for diabetes. And in fact, those things contribute to overweight and obesity. And even more importantly, they contribute to inflammation, sleep disturbance, and hypothalamic pituitary adrenal axis dysfunction. So your HPA axis is involved in the way that your body responds to stress. And in fact, some of the ways in which your body responds to stress, especially chronically, disturb insulin, how insulin works. And so stress is actually correlated with problems with managing diabetes, and sleep is sometimes underrated, but also very important. So all of these things, it turns out, are implicated in both depression and diabetes. And the real take-home message from this kind of complicated chart is that not just that depression and diabetes are interrelated, but the factors that actually contribute to both of those experiences are also interrelated. So really treating one or the other is in some cases like two sides of the same coin. And this chart is just another way to illustrate that interaction so that you can see that feedback loop of depressive symptoms and behaviors that are problematic in terms of managing diabetes, but also contribute to depression. And once those kinds of behaviors are reinforcing each other, that contributes to poor management of diabetes and increases the likelihood of complications. And you'll see on the side there, that is a very recent article from Zimbabwe, actually, but pointing out that adding the layer of COVID on top of all of this means that self-management creates more challenges for self-management, and that it's important to understand in terms of culture and location and resources what's going on so that people living with diabetes can develop the best plan possible in the context of, COVID affecting management and medical care and access and diet and all kinds of factors potentially. And that's why in Module 2 of CARPHA guidelines that CARPHA quite rightly emphasizes the behavioral and psychological dimensions of diabetes management, and they specifically recommend screening patients with the PHQ, which you can see right there. It's very easy to use in care settings. I imagine that most of the physicians in the audience are quite familiar with it. I would just point out that this is another excellent research opportunity because this instrument is used quite broadly, but I am not aware of any studies establishing psychometric support for its use in Caribbean. So that would be a good thing for somebody to do. So not just depression, all right? People with diabetes have 20% higher lifetime prevalence of an anxiety diagnosis. And in fact, anxiety has similar biological correlates to depression that were illustrated in the chart that I showed you earlier. The other diagnosis that sometimes gets missed is eating disorders. In fact, women with type 1 diabetes have double the risk of developing eating disorder. And if you think about the issues around having to think carefully around diet, you could see how that interplay might elevate risk. And so that is an important thing to be aware of. And I want to shift a little bit here and point out that the implications of diabetes for mental health and the implications of mental health for diabetes don't depend on a formal diagnosis from a psychiatrist or a psychologist. And I think it's important to recognize if, somebody with diabetes meets criteria for a diagnosis of depression or an anxiety disorder. But that isn't the only reason to pay attention to mental health. And just as diabetes, unfortunately, has some stigma attached to it, so do mental health diagnoses. And so I, as a psychologist, I'm pretty cautious about labeling. And I think that that is a good thing to keep in mind. And you can think about mental health and well-being without regard to psychiatric labeling, right? And one of the important phenomena in diabetes is something called diabetes distress. And this chart here, this graphic, summarizes experiences that can contribute to the distress that people living with diabetes can feel, right? There's the burden of living with a chronic disease. Many people experience fear of failing at keeping up with all the things that you have to do to manage diabetes. Emotions like fear, angst, or despair sometimes happen, feeling of life being controlled by diabetes, of being restricted in terms of the things that you'd like to do. Feeling of not being supported by healthcare providers, even healthcare providers, you know, that are well-intentioned and good. The experience of the patient is not necessarily what healthcare providers are trying to provide. And it's important to check in with people to see how they're feeling about their care. Social isolation, feeling a lack of social support, and all kinds of other quality of life issues, including just generally how people are feeling on a day-to-day basis. So that list is not really even exhaustive, but it points out that there are multiple aspects of living with diabetes, and in particular, with a recent diagnosis of diabetes that might cause distress. And this is really a very common experience, at least 1 in 5. I suspect that that is an underestimate. And just to reemphasize, this is not really a psychiatric diagnosis. It's a description of feelings that people can have in response to living with diabetes. And so diabetes distress and depression have some overlap, as you can see when you look at these symptoms. So the symptoms on the left listed there are the symptoms that are in the official criteria for diagnosing a major depressive disorder. And the symptoms on the right are what we know from learning from people living with diabetes about things that they have reported that they experience, right? And so you can see that if we had drawn these in circles, that the two circles would be overlapping. But it's important for clinicians to realize that both of these aspects of experience, that both of these constructs are important to assess and understand when you're working with people with diabetes. And in fact, the instrument there that I have included at the bottom, the diabetes distress scale, is specifically designed to get at patients' experience of diabetes distress as distinct from depression. It's free, it's open source. Some of you may be familiar with it. It's another scale that needs some research to make sure that it works well in the Caribbean, but I think it is a good resource to use, and even if the actual specific score needs further evidence in the Caribbean to support, it's also a good way sometimes to start a conversation with patients about the emotional and psychological aspects of their management of diabetes. So diabetes burnout is related to diabetes distress, and in fact, in some ways is is the sort of next step if diabetes distress becomes more overwhelming, right? And you can see, so this particular graphic has to do with type 1 diabetes, but it's not exclusive to type 1 diabetes. Certainly type 2 would be included. And you can see these symptoms of burnout, right? Irritability, feeling exhausted, alone, isolated, overwhelmed, pessimistic, down mood, feeling like you're not successful, trouble keeping motivation up, feeling like you're giving up, having conflicts or arguments with caregivers, with family members, with yourself. All of those things can happen. And also, people who are experiencing burnout often just don't keep up as well with all the details of management, like checking sugar and paying attention to diet and so on. In other words, it's kind of like they, reached a point where it's just kind of overwhelming. People give up. So this is a really important aspect to keep in mind. And the 3 points on the right there are, I think, especially important. If you are starting to feel this way, that getting your multidisciplinary, that means not just your doctor, all the people who are involved in your healthcare team, involved and letting them know what's going on, recognizing that doing everything perfect all the time, every day, is probably not a realistic target for anybody. Right? And so doing well and doing perfect are two different things, and doing well is very good. And it's really important to reach out to people who understand. And sometimes that might be family or caregivers, but this also speaks to the role of reaching out to support groups and other people living with diabetes. Historically, traditionally, these were in person. Of course, now, and even more in 2020, right, the ability to connect online with people who don't necessarily have to be physically near you is there. And this just points out that for everybody involved, from patients to caregivers to healthcare policy planners to politicians, that there's a system here, and there are interventions that help at the individual level, and there are factors that are much broader, right, in terms of the community, the organization, funding and access to healthcare, environment in and outside of healthcare, food security, supporting diet, right, access, financial considerations. There's a lot there in that graphic, but the point is that there are a lot of there's a lot of interplay between levels and systems that can facilitate people effectively managing their diabetes and promoting quality of life, and there can be barriers too. This is just a graphic from Australia, actually, with strategies for coping with diabetes burnout. And some of these are common sense, but I think they're important to keep in mind. Share the load. You don't have to do everything by yourself. Remember to give yourself credit, even for small achievements. You don't have to accomplish everything in one day or 1 week, but you can make progress incrementally. Speak up and talk when, and that includes your professional support system and your family support system and your friends. Keeping things inside when you're feeling frustrated or you have questions tends to build up and lead to negative outcomes. Using language that is less pejorative. This is an interesting one, right? Using words like high or low blood sugar and instead of good and bad. That's a very psychological intervention to reframe the kind of language you use. But the point is really, if your blood pressure, or your blood sugar goes up or down, that it's not really a value judgment on how you're doing or you as a person, right? It's important because the levels, high or low, have implications for health. And paying attention to essential elements of mental health, right? So if you'll notice, these are good for everything, right? Including depression and anxiety, but also diabetes, right? So the take-home points here are rest, recreation, regular exercise, positive relationships. Those are helpful for everybody across the board. And this last slide here is has a graphic there pointing out that stress actually affects insulin and blood sugar levels, so that managing stress is really part directly of managing other aspects of your diabetes, and paying attention to feelings, talking to your healthcare providers about how you're doing, not just about your sugar levels, but how you're doing. Feeling free to talk about any negative reactions that you might experience in other relationships or other social settings. Ask if help's available for costs. You know, in the region, there's a variability in costs, and there's a variability in what is available in the public systems versus the private systems. But, you know, if finances are an issue, and in the context of COVID, finances are an issue for more people than usual, ask if help. Don't be shy. Ask if help's available to meet the costs. Talk with family and friends. Allow people to help if you need it. That doesn't equate to burdening people, but allow people to help if needed. Talk, pace yourself, do one thing at a time, and particularly because managing all of this can feel overwhelming, you need time to rest. And so take time to do things you enjoy and give yourself a break. Just one last slide, really aimed at the physicians in the audience. We mentioned this earlier. So if you're treating patients with existing psychiatric diagnoses, it is important to remember that diabetes rates are higher in people with schizophrenia baseline. At least a lot of studies suggest that. But the risk for diabetes is exacerbated by the atypical medications. And so you can see my little color-coded list there that points out that olanzapine and clozapine are especially risky. And if you have patients who are taking those medications, it's really important to pay attention to their metabolic functioning. And if, particularly for patients that have lower risk factors, Geodon and Abilify are probably better bets to start. Certainly merit serious considerations, and some of the other common medications have moderate risk, and monitoring is important. There's a little bit of research suggesting that people who are using antidepressants continuously might also have some elevated risk for diabetes. That study controlled for some confounds, but not necessarily everything. It's not clear. I think that a reasonable course of action would be just to be aware and to do appropriate screening at appropriate intervals for patients taking antidepressants. And last slide is recommendations. which I think are very much in line with what the previous experts have talked about today. Multidisciplinary care is important. Incorporating mental health is essential. Routine screening for psychosocial problems, depression, diabetes, distress, anxiety, eating disorders. We didn't talk about cognitive impairment because there's not enough time, but that is also important. And in addition to screening, integrated care that provides appropriate support and also more systemic interventions to improve access to care and quality of life is important. And that concludes my talk. Thanks very much. And those are a little hard to read, but I'll make a copy available for anybody who wants to look at references.
Thank you very much, Dr. Campbell. Thank you for this presentation. At this point in time, we are going to indicate that the post-webinar poll would be opened to you, our attendees, webinar attendees this afternoon. And again, 6 questions, for you this morning on this poll. At this point in time, while you're answering the poll, I will turn over and invite Dr. Davidson to comment on the availability and how it is that you can access the diabetes guidelines, CARPHA's guidelines for diabetes management in primary care, because there have been quite a few questions on access and availability. Over to you, Dr. Davidson, to address this question to the wider group.
All right, thank you. Just to say, the guidelines are available on our website. We have shared the link in the chat for you to access, and we'll be sending a limited amount of copies to the member states. So we'll have some in print that we'll be sending out to member states, CARPHA member states. However, you can access it currently right now online. Thank you.
Thank you very much, Dr. Davidson. Dr. Davidson, just for clarification, would this be access to the guidelines to all of the modules, or is this just with regards to modules 3?
No, it's with regards to module 1, 2, 3, and 4, and we'll have 5 available shortly, but all 4 modules are online now. Yes.
Okay, great.
Right.
Thank you very much for this.
Yes.
I remind you, if there are any questions, technical questions with regards to the 2 presentations this morning, that you're able to do so in the interim as you answer the polls, that you can do so in the question and answer tab at the bottom of your screen. Some questions have been asked, but these have been answered during the presentations. And so we invite you, if you have any additional technical questions for the presenters this morning, to be able to do so. Thank you again to our captive audience. We had during the space of the morning, we've had over 100 participants in the virtual space joining us this morning. And as we speak to the new COVID era, as we speak to what happens after COVID, we are moving or shifting to what is a more connected era, an era where we're able to have virtual trainings such as this one, and able to demonstrate the effectiveness of such trainings in terms of being able to attract a significantly large and captive audience, something that may not necessarily be feasible with a face-to-face in a face-to-face environment in terms of the number of participants from the number of countries that we have present with us here that we've had present with us here this morning. We're moving towards a more connected era, and we heard some of our panelists address it in terms of the need now to give consideration to telemedicine as a means of engaging and remaining connected with individuals who are living with diabetes. A new normal where we want to be able to improve communication with community and to look at the entire community who is involved in providing care for persons who are living with diabetes. And these would be individuals who are trained, medically trained, for example, as well healthcare providers, as well as the laypersons who provide care at home, family support, community support. And as we wrap up our presentations today, I want to focus on I want my take-home message to be the last paragraph from the module, that the journey to wellness is filled with little steps that you take on the path. If you lapse on a good habit, don't give up. Try and try again. Changing life habits can be challenging, so persevere to do better and to be kind to yourself and to others. Allow me to take this opportunity to wish you all of the best for the festive season. And as you embrace all of the new norms for the festive season in this new era, to remember to be kind to yourself, to be kind to others, and to keep to the forefront the messages that we have shared with you with the last 4 webinars that we've had as it relates to the first 4 modules on the CARPHA guidelines for the management of diabetes in primary care. Good afternoon all, and thank you again for being with us and joining us at today's webinar. You're able to access the webinar evaluation code that would allow for you to provide some feedback, to provide valuable feedback to us on today's webinar. And please correct me, Dr. Davidson, if I am not quite right on the statement.
Sorry, could you repeat?
Shared?
Pardon?
Yes, I said Abby has now shared with in the group chat the link for the webinar evaluation that would allow our participants to provide valuable feedback on today's presentation. Sorry, Dr. Davidson, we do have one question that we missed in the chat with regards to you having addressed pre-exercise testing and approach for situations with hyperglycemia, not doing exercise. You've been asked to comment on that again relative to the persons who are relatively asymptomatic at the time. So if you're able to provide some brief comments on this for one of our persons in the space this morning.
Yes, thank you. I spoke about pre-exercise testing with respect to the recommendations as it was related to the WHO recommendations, whether you need to do medical assessment before engaging in physical activity. And then I spoke to hyperglycemia in the case of a blood sugar of greater than 13 millimoles per liter. That is not recommended that you engage in physical activity at that time. That's a general recommendation. But you will need to look at it case by case. But the general recommendation is you really shouldn't exercise at that time. You really want to get the blood sugar under control. So in a state of hyperglycemia of 30 millimoles and above, that's the recommendation. Yeah. So I hope that cleared up that question, which seemed to have been twofold.
Thank you for that response, Dr. Davidson. And again, just reminding persons that Abby has shared in the chat with us the access to the evaluation survey to better allow CARPHA, to better allow us to understand the webinar and its usefulness to you, as well as providing further support to you in the future as it relates to training in the areas of diabetes management and the implementation of the guidelines.